Overall survival in renal cell carcinoma with pasopanib versus sunitinib.
Of course, we know what this is right away. We know it's a kidney, even at this power. Um, it may not be the world's most normal kidney. It looks like some of these vessels may be a little thicker than they should be, uh, cleft or vascular space. We now are seeing some other type of thing. We are seeing something that doesn't look like kidney. In all honesty, it looks like what we are seeing, the majority of the cells here look like they are cells with centrally located small nuclei surrounded by a fairly abundant amount of foamy cytoplasm. Clear cell carcinoma. Sometimes carcinomas of the kidney have a more glandular pattern, but more often than not, you can see that most of these cells here, even though they're small and uniform, these are malignant cells, folks. It's just not one that's very pleomorphic or bizarre. These are malignant cells. They're very malignant. They infiltrate quickly directly into the veins. It's one of the four types of carcinomas you're likely to see going early to bone as well. This is clear cell carcinoma of the kidney. And no matter what part of it we go to, we can see once again cells with small, centrally located nuclei surrounded by foamy cytoplasm. Clear cell carcinoma of.
In the August 22 issue, we report on a phase 3 trial showing a non-inferiority with respect to progression-free survival of pasopanib versus sunitinib as first-line treatment for clear cell metastatic renal cell carcinoma as assessed by independent review. Now report the results of the final analysis of overall survival. Overall survival has a secondary endpoint, was defined as the time from randomization to death from any cause.
Sunitinib is the reference standard first-line treatment for kidney cancer based on a large trial that compared sunitinib to interferon. Pazopanib was developed a little bit later, and the trial suggested similar efficacy but a different safety profile, in certain ways more attractive. So this was a large 1,110 patient trial. I think it's the largest trial that's been conducted to date in patients with advanced kidney cancer. Non-inferiority trial comparing pazopanib to sunitinib in first-line therapy for clear cell cancer effects. We looked at the safety profile, and we found that some side effects were worse with one drug and some side effects were worse with the other. The side effects that occur more frequently with pazopanib are increased elevation of the liver function tests and some weight loss.
The final analysis of overall survival in the intention to treat population was to be performed when 650 patients had died or 2 years after the last patient was enrolled. Overall survival was summarized by means of Kaplan-Meier curves and compared with the use of a stratified blood rank test. Subgroup analysis according to Memorial Sloan Kettering Cancer Center risk criteria show a median overall survival of 42.5 months in 151 patients who received pazopanib and 43.6 months among 152 patients who received sunitinib.
past couple of years, the frontline treatment is all sunitinib. It's 50 milligram once a day for 4 weeks, followed by a 2-week off regimen. And when patient on the trial, almost all of them experience some kind of fatigue, and diarrhea, and mouth soreness, things like that. It's very effective, but some people, most of people experience the toxicity, the side effect that I just mentioned. But it's great drugs, but it comes with some price. And that's why the COMPASS trial basically was comparing a daily dose of pazopanib 600 to 800 milligram without interruption to the 4 weeks on 2 weeks of sunitinib. Basically, the efficacy is there's no inferiority trial. Basically, show these two drugs is very similar in terms of their efficacy in patient. But the problem is that if you ask patient in terms of the quality of life, the fatigue score, in the mouth soreness and things like that, and patient prefer pazopanib. That's why we think the pazopanib will be recommended as a first line treatment if based on the quality of life.
The median overall survival was 26.9 months among 322 patients who received pazopanib, 95% CA, 23.1 to 35.6, and 26.1 months among 328 patients who received sunitinib, 95% CI, 20.7 to 31.6 in a group of patients with intermediate risk disease. The median overall survival was 9.9 months among 67 patients who received pazopanib, and 7.7 months among 22 patients who received sunitinib in a group of patients with poor risk disease. 34 patients who received pazopanib 6%, and 23 patients who received sunitinib 4% continued on study treatment. The median on treatment period was 8 months for pazopanib and 7 months for sunitinib.
We have heard the results of the COMPARTS trial presented by Dr. Robert Motzer from Memorial Sloan Kettering Cancer Center. This is an international randomized trial evaluating head-to-head two oral angiogenesis tyrosine kinase inhibitors for the treatment of patients with metastatic renal cell carcinoma that have had no prior treatment. The aim of this study was to prove in a head-to-head fashion whether or not pazopanib was actually non-inferior to sunitinib. The results of this study are really quite fascinating. What they showed, first of all, in terms of progression-free survival, the primary endpoint, the hazard ratio is 1.047 with an upper boundary of 1.22. So pazopanib was clearly not inferior to sunitinib.
The two most common reasons for treatment discontinuation were disease progression in 311 of 554 patients who received pazopanib, and almost 56%, and in 329 of 548 patients who received sunitinib, 60%, and adverse events who received pazopanib 24%, and 107 of 548 patients who received sunitinib. That's the 20%. Safety results were consistent with those reported in our article. Both study angiogenesis agents or inhibitors of the mammalian target of rapamycin were administered in 306 patients who received pazopanib, 55%, and in 299 patients who received sunitinib.
In what's called the adjuvant setting. The adjuvant setting stands for the cancer coming back in patients who are at high risk for cancer.
The strata were based on Karnofsky's performance status score, based on the level of lactate dehydrogenase,